So the next couple of speakers, we've got a very nice lineup. You're going to get all the nuances of how to modify your lifestyle. The next young man is a cardiologist, Dr. Faisal Nabi. He is professor at the DeBakey Heart Institute, Methodist Hospital, professor at Weill Cornell School of Medicine. He's an expert in imaging the heart with CAT scan for calcium scoring. So I'm really delighted that he's here. He comes from mainstream medicine, and he's going to give us his thoughts about calcium scoring. Thank you.
Well, hi, good morning, everyone. Good morning. I'm really appreciative of Dr. Ali to invite me to such an innovative and unique conference. In fact, myself, I'm hoping to learn a lot today. As Dr. Ali was saying, I am a non-invasive preventative cardiologist here in town, and one of my focuses is prevention and cardiac imaging. So I think today, I hope at least, I hope my talk doesn't get too much into the nitty-gritty of cardiology, but the field I'm going to be discussing has a lot of literature out there about it. And there's a lot of data, there's a lot of science. It's been studied now in hundreds of thousands of patients. So I hope to share with you, the story of calcium scoring and a little bit about atherosclerosis. So what do I plan to do today? Kind of my outline of my talk. I'm going to tell you some basic truths of heart disease here in the United States and the basics of heart disease, atherosclerosis. We're going to talk about some current pitfalls of evaluation that as physicians we frequently do. I'm going to propose to you a better way of doing things, something using called a calcium score, which helps me to detect subclinical atherosclerosis at a very, very early stage. I'm going to tell you a lot about data, and this is where I hope I don't lose you. I know we have a lot of non-physicians in the audience, but I will try to keep it simple as best as I can. And then I'll tell you how I, as a physician, use this information in my own practice to hopefully for the betterment of my patients. So let's begin. So I thought I would begin with some facts. So the first fact I'd like to for you all to know is that cardiovascular disease is the #1 cause of mortality in the United States and all of the industrialized, westernized countries. It's said that every 38 seconds someone is having a myocardial infarction or a heart attack. And if you look at this graph, this is just a graph showing you that despite all the cancers that you've heard about, heart disease really is almost double the amount of mortality and morbidity from heart disease, far outweighs that from any cancer. Now, cancers, as you may know, have a lot of different types of cancers we have. Heart disease has one underlying pathology, and that's atherosclerosis. And there's many different terms we can use for this word atherosclerosis. You can call it hardening of the arteries. You can call it fatty deposits in the heart. Many different terms. But the basic component of cardiovascular disease is this term atherosclerosis. And we'll talk more about it. And how it leads to morbidity and mortality is really through two main ways. It'll either cause you to have a stroke or you'll have a heart attack. Some patients, because this affects every vascular structure in the body, some people can also have blockages in their legs and unfortunately lead to gangrene and amputations and treatment thereof. But this is what I wanted y'all to know about atherosclerosis. This is a chronic disease. It actually starts very, very early in life. It's said that, if you look, believe it or not, in our 20s, if you were to image the aorta and some of the other vasculature, already what they call fatty streaks or fatty deposition in the walls of the arteries has started. And this gradually progresses. Mechanisms are many. You'll probably hear a lot during this conference. One of the things that we've really learned in the last several decades is that atherosclerosis is an inflammatory disease. There's actual markers of inflammation that are going on in the walls of the artery. There's deposition of cholesterol in the walls of the artery. The cholesterol gets oxidized. It's taken up by macrophages. This process then leads to a lot of substances being secreted in the walls of the artery that can eventually one day, as the plaque gradually grows, and this can take a phenomenon of decades, somewhere in your 50s and 60s, one of these plaques can rupture where you can have an abrupt cessation of flow, and you can have either a stroke or a myocardial infarction. So I think, the purposes for this talk, for our purposes in this conference, of course, are, what can we do to prevent the #1 killer of Americans? So another thing you should know is that obviously, since it's the #1 killer, we're spending a lot of money on this disease. It's said up to 17% of our overall national health expenditure is spent on cardiovascular disease. And I've put a comparison there as how much money is spent on cancer, and you can see that we're almost 3 times the amount of dollars spent for cancers is spent on heart disease. And what the real scary thing is, and what you've heard from our earlier speaker, is there's a great fear that because of the way the population is aging, risk factors are increasing. We know as a nation we're getting more obese. There's a very big fear that these costs are going to go further and further high. And as you know, this is a major issue. We see it playing out at the national political scene. There are a lot of efforts being done on how we can control healthcare costs, and heart disease is one of those drivers. Our population is aging, and our risk factors aren't getting reduced. And the fear is that heart disease will become more and more rampant and, of course, cost us a tremendous amount of money. The third truth that I want you to know, and would make sense, is prevention, if you can do it, is definitely the way to go. It's a lot cheaper to prevent disease than it is to throw a lot of expensive money trying to treat the complications of it. Now, I'm a cardiologist, and there's probably several cardiologists in the room, and I'm sure all of us know we spend a lot of our time doing a lot of very fancy, innovative things that really have prolonged survival, but it's always at the end of extremes of disease. When the patient has had heart attacks, when they've had a lot of morbidity in their life from this disease process. If we can address these issues much, much earlier in time, we can really reduce costs, and we can prevent a lot of patients from going on from suffering from heart disease and atherosclerosis. So the way we have, as cardiologists, we've been treating patients, and our way of thinking all started actually since the 50s. This was a landmark study. It was called the Framingham Study. Some of you all may know about it. But it was the first time in a population-based cohort they figured out risk factors that place a patient at risk for heart disease. And this and another similar study, this was a very large study in almost 25,000 patients, showed that there are risk factors that contribute to early onset of heart disease. And these are common things that everybody knows about: high blood pressure, diabetes, cholesterol, smoking, overweight, stress in your life, poor diet. All of these, through these landmark population cohort studies, were identified. If you had these risk factors, these were people who were dying from heart disease. At the same time, they identified some good things. Obviously, if you have low stress in your life, you're eating a lot of fruits and vegetables, and maybe some alcohol in moderation, these were things that had been shown to be of benefit. And so, and just in the previous slide, the other point to make out of this is that these risk factors are additive. So if you have one risk factor, you have a certain amount of risk for heart disease. But if you start adding in on top of high blood pressure, maybe diabetes, maybe cholesterol, maybe smoking, you can see from this graph that as your risk factors increase, your risk for heart disease progressively increases. And so hence why a lot of the physicians, and y'all have all visited physicians, we start looking for these risk factors and trying our best talking to you about how we can reverse it. So the American Heart Association really wants you to, and again, this is how we've been doing things since 1950s, is really focusing on 7 basic principles. And these are, there are a few of these. There's about 4 or 5 numbers you should know about yourself. What are those? You should know your weight. You should know your blood pressure. You should know your glucose, your hemoglobin A1C, and you should know your cholesterol. So these are some basic numbers you should know about yourself. And if a lot of y'all may be employed now by a lot of employers, now they're checking you every year. They want their employees to be healthy. These are kind of the metrics that they're tracking. So the Heart Association has always recommended on patients who come in that as a physician, in the back of my head, when I see someone, I'm thinking about these things, that I hope to have the time to be able to make sure their blood pressure is well controlled, talk to them about a healthy lifestyle, eating right, and so we can control a lot of the risk factors that predispose to atherosclerosis, which, if not controlled, over decades can lead to something bad happening, like a heart attack. And as cardiologists, I have a lot of risk tools because we have such strong data from population studies. I can see one of you in my clinic. I can put in all your variables, your weight, your blood pressure, your LDL, your HDL, and I can compute what your risk for incident heart disease is at 10 years. And so we have all these fancy calculators. There's a lot of different ones. The American Heart Association and the ACC have their own called the pool cohort equation. And this is an everyday thing for us in clinic where we calculate the risk. And the concept for you should be very simple. If we identify a high-risk individual, it makes sense that we should be most aggressive with that type of person. Whereas the lower-risk person should, theoretically have the lower risk and be, and you can, be less aggressive with them. So we're trying to identify high-risk people. So our president, number 42, you can imagine he was in the office from 1993 to 2001. He was a runner in office. He was known to be fond of fast food. There's several pictures of him on the internet enjoying McDonald's. But he had the best health care you had. He had annual physical checkups. He had probably some of the best physicians that anybody has access to. And, throughout his presidency, he was having annual checkups, and he was actually having annual stress tests. So if anybody you would suspect to do very, very well, it would be someone like our president. He leaves office and a few years later, in 2004, is admitted for chest pain, and he's found to have arteries that are more than 90% blocked in several arteries. Now, for those of you who are concerned, this is not a HIPAA violation. This is all public information on the internet. So, in fact, all these pictures are from the internet. So, and he needs a 4-vessel bypass. So, this is a wake-up for me as a cardiologist. I do this all day long. I see people, I do what's recommended, and yet I see this often happen. Here you have a young man, prime of health, had the best health care that anybody could imagine, annual checkups. He was advised on a statin. He decided not to take it. 4 years later, ends up needing a quadruple bypass. What happened? Can we do better? And that's really the mantra for me as a cardiologist. Can we do better? So, I think that brings us to the truth number 4, that if you are going to do prevention, you want to do it with the most accurate way you can, because obviously your success depends on your accuracy. So you really have to be accurate to identify those patients who truly are at a significant risk in order to catch them early, put them on the right treatment plan, and to reduce their risk. So it really comes down, what is the best what we can do? So these were the Life's Basic 7, and I only put this here is because it has an inherent problem. The problem is all this data that was generated as to what risk factors are, they are accurate, it is true, but the problem is they're all developed from population-based cohorts. So you take a population of 25, 30,000 people, and you get the average results for that population. But you or I could be very different from the population. So if we were to really come down to a better way to do preventative medicine, it would be at an individual person level, at an individual person base level where I can advise and identify an individual person's risk, looking at based on his genetics, based on his individual scores, test results, et cetera, et cetera, et cetera. And so that's one of the big problems with these population-based studies, really, that when it comes down to the individual person, it may or may not apply. I'll give you more examples. Jim Fox, some of y'all may remember him. He is known as the father of modern day jogging. And he popularized jogging, was a marathon runner. You can imagine if you're running 26 miles per day, you are in incredible shape. And no doubt he was. I think he ran over 13 marathons in his lifetime. He dies while jogging at the age of 52. All right? So autopsy reveals significant atherosclerosis in all his coronary arteries. We're not doing something right, right? This could be us. All of us may, enjoy walking or some exercise. Something is not right. There's a very big discrepancy between the risk factors that a patient may demonstrate and really their individual risk. And actually, if you go back and look at literature, this is coming out to play, and it's not surprising. This is a slide of almost 88,000 people who had an incident heart disease event. And they went back and said, okay, you've had your heart attack. How many risk factors did you have before you had this first heart attack? And the results are kind of shocking. Almost 60% had 0 to 1 risk factors. So there's a tremendous amount of disconnect between risk factors and what may happen to someone. It just goes to show you that atherosclerosis is not a simple disease. There are a lot of different players to this, a lot of things that we're trying to learn and understand. It's not a simple disease. So just, again, highlighting the point that coronary events occur in patients who we thought were low risk. More examples. This is a sample of 136,000 patients had their incident heart attack from a giant ACC registry. They went and checked their LDL. Your doctors are always harping about your LDL. 77% had LDLs less than 130, what we consider normal. So again, the gap between, the risk factors, although in population studies they predict risk, but at an individual level, there's a lot other things going on. Let me give you another opposite example. Winston Churchill. Y'all probably, there's historians here who probably know way more than I do. All I know is he has this famous quote, "I must point out that my rule of life is prescribed as an absolutely sacred right, smoking cigars and also drinking of alcohol before, after, and if need be, during all meals, and intervals in between them." Every picture you'll find on the internet, he has a cigar in his hand, and he's got a big, ruddy complexion. This is a gentleman who has tons of risk factors. He should have died very early. No, he dies in his sleep, age 91. So does this show there's a God, or is there something, there's other things we need to learn about this disease? And, so what is the problem with all this risk factor assessment? What's wrong with these risk calculators that I use in my own clinic? Couple of things. Number one, they're all strongly influenced by age. Obviously, the younger you are, there's probably less people in these cohorts that are being examined. The young people in general tend to have lower risk. And so you lose a lot of sensitivity if you're a young person in these population cohorts. The opposite is also true if you're elderly. Just by sheer numbers, specificity tends to be a lot lower. These people end up getting over-treated, although their risks may be very low. A lot of this is, data that we use in these formulations are based on patient accounts telling us what they have. These are also often, because it's a risk-based calculator, you can go to the internet and Google this and you can put your own numbers and see what your risks are. These are at a one-time, evaluation. So we all know we can improve our glucose values, we can improve maybe our LDLs and things like that, but at the one-time initial that you may, when you're the sickest, you put your worst-case single-day measurements and you're predicting a long-term risk. But really, the main issue is that development of atherosclerosis is extremely complex. It can't be just pinpointed to risk factors alone. There's a lot of other things going on: genetics, epigenetics, the environment that we live in. All of these go into effect to identifying people with the predisposition towards atherosclerosis. So there is a lot of interest to do things better, and that's really one of my interests, is as preventative cardiologist, if my risk factors in predicting atherosclerosis are moderate, what can I do with all the tools that we have now to make our risk prediction for those better, so I can identify those patients with early disease much early on, get them started on the right lifestyle, the right therapies, to hopefully improve their risk and hopefully improve our nation's health as a whole. So the thing that I'll be talking the most to you about is a test called a calcium score. This is a test that identifies subclinical atherosclerosis. So as I had told you, atherosclerosis can be really a quiet disease for many, many decades. If I can identify that patient who has already developed disease, this patient population is a high-risk cohort. I'll show you a lot of data on this coming up. And I can, and based on his test results, I can optimize my therapy to his level of risk. Okay, so I'm kind of making that same point. So here I'll transition to really the next part of my talk, really spending a lot of time on calcium scoring, what it means, and really give you an understanding for this test. And I'm sorry, this is where the data comes out. I'm a cardiologist. We're very data-driven people. And, I'll try to make it as simple as I can. Okay, so it turns out if you take pictures of atherosclerotic lesions, at all, bear with me, at all stages of atherosclerosis, there's many different stages of atherosclerosis as the disease becomes more intense. One of the things the pathologist found was there was always deposition of calcium. And we can go into why that is, and I think I'll hint upon it in upcoming slides. But the main thing I want you to know is that if I have a test and I can identify calcium in your coronary arteries, you have the disease. There is no other disease process that deposits calcium in the heart arteries other than atherosclerosis. This has been proven by all of these autopsy studies, by histology, and this is one clear point you all have to understand. Presence of calcium in the coronary arteries, no other disease process other than atherosclerosis. You identify the disease, that patient has the disease has started. One of the reasons what they think is happening is calcium is, the body is smart. It's always trying to repair and heal itself. When you have these fatty deposits being deposited in the wall of the artery, these are very thrombogenic should the bloodstream see them. That's what causes a heart attack. So in order for the bloodstream not to see this large necrotic lipid pool, the body forms a layer of calcium around these plaques. So one of the signs of a chronic stable plaque is if we see very dense calcium in some of these studies that I'm going to be sharing with you. Whereas the plaques that tend to rupture and cause heart attacks and strokes, these in general have a lot less calcification. We call it spotty calcification, but they still have calcium. So just hitting as to why the body, why we may deposit calcium around atherosclerotic lesions. There's been a lot of studies. These are all from autopsy studies looking at coronary artery segments, comparing them to histology, that if you look at the amount of calcium that you have, that amount of calcium linearly predicts the amount of atherosclerosis, total atherosclerotic plaque that's present in the coronary arteries. So this will become important because these calcium score tests that I do gives you a number, an amount of calcium that you have. But what's really more important is that indicates to me the total atherosclerotic plaque burden. Because you can think of atherosclerosis like the tip of the iceberg. So the calcium is really just the tip of the iceberg. It's really all the other atherosclerotic plaque that it tells us is present. And this is all non-calcified plaque. So this is where this test is so helpful, is that because it's very hard to identify non-calcified plaque, we have a test that can find the calcium, but it's a total marker of how much total atherosclerosis that the patient has. We have a lot of fancy tests in medicine and science to be able for us to identify calcium. This is not the point of my talk. We have ultrasound, invasive ultrasounds. We have optical OCT, what we call optometric tomography. We have CT scans. And the test that I'm going to be really talking to you is on this bottom right-hand corner. It's called a calcium score. And in the next few slides, I'm going to spend a lot more time discussing it. How many in this room have had a calcium score? Okay, good. Quite a significant amount. Maybe by the end of the talk, all the hands will be up next year. But this is a very simple test for those who've had it. You literally walk in, you come to our CT machine, you lie on the machine like that. You really don't need any IVs. There's no pins, no needles. You literally hold your breath for maybe 7 or 8 seconds. We pass x-rays around your heart, create a 3-dimension image of the heart. And anything that's very bright white, because this is a non-contrast study, there's no contrast that's given, calcium will show up just like bone. It'll be bright white in your coronary arteries. So this is a patient where I can just, in 10 seconds, tell him, sir, you have atherosclerosis. You have the disease has started, and if you don't do something about it, you are at risk for an incident event. Why this test, I'm here to talk to you about this test today, is because instead of using population-based risk scores, this is an individual person-based test. So here I'm actually individually, by checking their calcium, I'm checking a patient's individual number and therefore his individual risk. So this is a very personalized approach to preventative care. Other good things about this test are, in general, we talked about the first two, that it's if you have calcium, you do have the disease, atherosclerosis, and that the amount of calcium you have indicates to us the amount of total atherosclerosis you have, both calcified and non-calcified disease. Not to get into going too much into it, but if it took us 10 seconds to perform, it takes us maybe another 30 seconds to quantitate a score. The scoring is done in a simple way. You identify an area of calcium. Anything more than about 3 pixels and greater than 130 Hounsfield units, the computer identifies as calcium. And that area is then multiplied by the density, a factor that represents the density of calcium that is seen. And you do that for individually for all the arteries and add up all the numbers. And you're able to get a total calcium score. And the way to think about it is a normal person should be 0. A normal person does not have atherosclerosis. So your calcium score should be 0. We have a score between 1 and 10, what we consider minimal. Between 11 and 100 is considered mild. 101 to 399 is considered moderate. And a calcium score greater than 400 is severe. So why is this number important? So this is where now I turn my hat into a cardiologist, and please bear with me for the next several slides. But I will try to make it very, very, hopefully as simple as I can and interesting as for y'all. So there were a lot of studies done. So people started seeing calcium. They started having a test very early on, EBCTs. It was there since, I believe, the late 60s. They started being able to identify calcium. Autopsy studies started to show that it's associated with atherosclerosis. So people said, hey, why can't we use this calcium score to predict whether our patient is going to have an obstructive lesion? And what they found was that it's actually very, very sensitive. So, you know, if the test is positive, you definitely have the disease. But if your test is positive, it doesn't necessarily mean that you have an obstructive lesion. So for those of you all who may be engineers in the audience, and cardiologists sometimes can be plumbers. So, you know, you have a pipe, and instead of the disease being a very lump-like lesion which is obstructing the flow of blood, it can be just lined along the vessel wall. So it can be it can be diffuse and non-obstructive. So what they found was that in those patients who didn't have any calcium, they never found any patient who had an abnormal invasive angiogram. They never identified anybody who had a blockage. So people started thinking, this test, you know, is good for something. You know, I mean, if your score is 0, I can tell you with confidence, not only do you not have the disease, you're not going to have anything obstructive for sure as well. And then there were a lot of other studies that came out. I'm a cardiac imager, so you know, I like to do things non-invasively. You may have gone for stress tests, and this is just data showing that, you know, if you had calcium scores below 100, you had almost no chance of having an abnormal nuclear myocardial perfusion study. So we never found any blockages. And these small numbers that are there may very well could have been, you know, misinterpretation of imaging data. Whereas as your score increased, you can see a progressive risk of finding an obstructive lesion. For those patients who have calcium scores of 400, you have almost a 25 to 40% risk of us finding an obstructive lesion on a patient. So, you know, as this data was coming out, this was people started, calcium scores were being done routinely. I think, you know, a lot of companies are out there offering you, you know, heart scans and total vascular, you know, checkups. A lot of them incorporate calcium scores. So people were doing these studies, calculating and obtaining a lot of data. And one of the sites published their registry data. They, you know, these were patients who had calcium scores, and they followed them the course of almost 12 years. And, you know, for those of you who may have statistics background or research background, I've heard in many lectures being told that, you know, the data with calcium score is some of the cleanest data statisticians have worked with. That the numbers are just so, you know, work out so cleanly and well without much, you know, manipulation. And some of the themes I'm going to talk to you about, you'll see in the next several slides. They found an amazing thing. They found, number one, they found that as your calcium score increases, your survival progressively decreased. So those patients who had a calcium score of 0, you can see they're almost bulletproof out to 12 years. There's few things in life where you can be given a warranty period for. And it seems And it seems with calcium scoring, if you have a calcium score of 0, your risk for myocardial infarction is less than 0.3% per year. You know, I think you have, you know, we often joke about it, you know, amongst my colleagues that you have more risk if you have a calcium score of 0 from dying in a car accident than you do from heart disease. Whereas as your score progressively increases, you can see the risk of an incident heart disease progressively increases. So those patients more than 400, which was the cutoff that I told you about severe, these patients have almost a 2% per year risk. And for a cardiologist, that makes you no different from a diabetic. That makes you no different from a patient who's already had a known heart condition that we had to do something for. So it identifies a patient with a very, very high risk. And what's interesting about this data is, you know, you can see out to 1,000, the risk continues to increase. And then this was recently published, you know, oh, okay. I think I may, for time, I didn't include it, but they've gone on to look at 2,000, 3,000, and the numbers just keep on going down. It gets worse. You know, it's amazing how reliable these numbers are. Many groups also started to, you know, there was always a question, well, you know, I mean, as we age, it's normal to form some calcium and things like that. But, you know, there was a lot of, this was a study in almost 45,000 people. It showed you very nicely that, you know, those, as you age, your risk of having calcium, of course, increases. But it also showed you that they are at people at very low age, I mean, at very advanced age who have very, very little calcium. And these people have a very low event rate compared to someone, you know, as their calcium score increases. It also shows you that a person who's young but has a very high calcium score has a much higher risk than a 75-year-old who has no calcium. So, you know, I think the true sign of aging is really how much calcification you have in your vascular arteries. Registry data is, for those of you all who are knowledgeable about statistics, can be kind of dirty. You know, as cardiologists, we love prospective studies, and even better than that, randomized controlled trials. So a lot of 4 studies came out, looking at prospective data on calcium scoring. And these were large-based studies. The most popular and most well-known and maybe most well-heard of in the community was MESA. This was a large population-based study that evaluated patients from 4 different ethnic groups, almost 7,000 patients. And they showed exactly the same results that you had seen in the other slides. If you have a calcium score of 0, you do extremely well without any risk here out to 7, 8 years. Whereas as your calcium score increases, they used a little bit different cutoffs, but you can see your risk with a calcium score of 300 is 9 times the risk, or almost 10 times the risk of a patient with a calcium score of 0. So these were now, you know, we were getting a lot of very strong prognostic data of what it means with this specific number, this calcium score. Not to go into too much details, but it's not enough just to show a lot of slides. You really have to show that a test is adding value to the care that you're already providing. There were on all these 3 studies that was demonstrated. They used some. They were able to demonstrate it using a C statistic that showed that calcium scoring, in addition to risk factors, significantly increases your ability to predict who is going to have an incident event. Calcium scoring also was then looked at with something called the net reclassification index, a lot of statistical stuff, but basically showing that, you know, when it comes to all these models, we're very good at identifying low risk, we're very good at identifying high risk, but it's the intermediate risk where, you know, it's always the question, which way do they go? And in the calcium scoring data, what they were able to show was that it reclassified correctly 55% of those intermediate risk patients. So we call that a net reclassification of 25%. And those were across the board shown on these very large prospective studies done all around the world. People made a...
3 minutes left.
3 minutes left, okay. I'm going to really hurry now. People really started to slice and dice this data in many different ways. They were able to show very nicely here that, you know, as your risk factors increase, your risk increases, as I had already told you. You know, we know that from the 50s. And we already showed you as your calcium score increases, your risk increases. But look at this. If you have a lot of risk factors and your calcium score is 0, you're at very low risk. Whereas if you have no risk factors and your calcium score is greater than 400, your risk is again greater than that patient who has many risk factors. So, you know, this is really goes above and beyond a value, you know, telling you about more than risk factors. People looked at lipids. This is just another slide showing you. I'll just point your eye here. These were patients with normal lipid variables. You could risk stratify them not based on their lipids, but actually based on their calcium score. This was data showing you, people always said, well, what about women? Women are always low risk. Yeah, that is true. Here was a study of women, ASC/VSD risks of less than 7. Almost 36% of these women had calcium, and they were found to have increased risk of mortality. What about in the very young? People say they're young, they're bulletproof, right? No, not really. This study of patients, people between the age of 32 to 46, middle age, 10% had a calcium score greater than 0. Wouldn't it be great to identify those and prevent them from having a heart attack? These were the very old. This is another slide showing you the very old. People greater than the age of 70. Calcium score 0, they did very well. Calcium score high, you know, they were having events. So it's really you know, its age is just a number, but it's really your calcium score that's more important. And then, you know, for cardiologists out there, this is enlightening to me. This was a study based on patients who had normal stress tests. Now, you know, normal nuclear myocardial perfusion studies. Now, with every normal study I do, I always get a calcium score, because what we were able to show was that up to 3 years, the nuclear has a very good warranty. It tells you that the patient will have no risk. After that, the risk is completely dictated by the total amount of atherosclerosis they have that's predicted by their calcium score. So it's really anatomy and physiology working together. And for those of y'all who are interested, our president does have a positive calcium score. Also public knowledge. We use calcium scoring in 2 ways. This was a patient who had a lot of risk factors. I put in their score. Their risk came out 5%. In the prevention guidelines, it's very important to do this, because in anybody more than 7.5% is recommended to have a statin. If you look at our prevention guidelines, which were just published earlier this year, the first thing they ask you to do, if your risk is between 5 and 7.5, it's kind of a gray area. They ask you to look for risk enhancers. These are patients who we know now have inflammatory conditions that predispose to early atherosclerosis. This patient of mine did not. But then the second thing is if they're not sure, you can get a calcium score. I checked, and this was now recommended in the guidelines. It's given a 2A recommendation. I checked on this particular patient. Their score was 288. So my risk factor tool told me I shouldn't do anything. My calcium score told me this patient's at high risk. So we escalated therapy on this patient, and in this study it showed that those patients who are almost 45% of patients who are who are considered for statin or statin is not recommended, you're going to find a lot of patients with positive calcium. Similarly, so this patient was prescribed treatment. Similarly, it's also been shown with calcium scoring, people really pay attention. When they see this result, they say, oh my God, I have the disease. They start getting their blood pressures under control, their lipids under control. Here's another person. He was high risk. His score came out to 10%. For us, that's as soon as you're greater than 7.5%, that's a recommendation for statins. He, as is seen here in this slide, he went on the internet and said, no, I'm not doing this. I've heard about memory loss, liver problems, my bones are going to hurt. Sorry, doctor, do something else. Guidelines actually now recommend if you have a patient like that who's unwilling to, you can consider calcium scoring. That's exactly what we did. His calcium score was 0. So this is now using this test to de-escalate therapy. And just showing you the power of 0. Here in this study, 44% of statin-eligible patients have a calcium score of 0. And those patients with calcium scores of 0, you can see how their prognosis is excellent. And in fact, we know that out to almost 15 years now, that if you're a calcium score of 0, considered low to intermediate risk, your event rate is less than 1% per year. So very, very powerful test that we're using to escalate therapy, and at the same time, we can use it to de-escalate therapy in the right patient populations. So the patients where it's not prescribed with statin, we use similar logic when it comes to prescribing aspirin. I won't delay too much time. You know, a real superior doctor prevents sickness, so I hope that's what my goal is. And I want you to know that here in Texas, we're one of the few states that it's covered by health insurance. Please ask your doctors about it if you're a good candidate for this test. It is covered by insurance. And I'll leave these summary slides on the screen for you.